Hi everyone. My name is Isabella Brown, and I'm a marketing associate at UVA. I'm super excited about today's event. I think that it will generate a lot of much needed conversation and reflection about the fertility space in today's world. As you all know, this year has been packed with surprises and devastation that no one really saw coming. So with a focus on reopening clinics post-lockdown, as well as combating racism, which is embedded in our healthcare and fertility systems, this panel will address how we can work to achieve the change that we all want to see. So I want to thank everyone for coming out today, and I especially want to thank our panelists who took time out of their busy schedules to have these important conversations with us and to educate all of us with their expertise and their experience. So Amy, I'll hand it over to you. Amy's one of our hosts today, and she's going to tell us a bit about herself before diving into the panel.
Sure. Thanks, Isabella, and thank you everyone for joining us today. My name is Amy Devrania, and I'm the CEO and co-founder of UVA. We're an early-stage women's health company that has developed an at-home test to monitor two key fertility hormones at home. So we monitor luteinizing hormone and progesterone quantitatively, so you can really learn what your fertility profile looks like. And the entire experience is meant to be personalized, so we don't compare you to whatever normal is, because none of us are that typical 28-day cycle. So UVA really embraces that, and we want to learn and educate you on your fertility. Another layer of this is that we've actually gotten a lot of inbound interest from clinicians to utilize the product for remote hormone monitoring. So you can really have the same conversation with your doctor about your body, and it's no longer a black box. I'd like to pass the baton to Kristen, who is also my co-host today. Kristen, go ahead.
Thanks, Amy. My name's Kristen Hodgden. I am the founder of the Fertility Tribe, and I'm definitely not one of those people with a normal, regular 28-day cycle. I have PCOS. I went through a little bit over a year of infertility treatments and IVF before conceiving my twins. They're now going to be 2, which is crazy. And I started the Fertility Tribe just as a way to sort of give back after my own journey, to support those going through infertility and share stories and resources. And that's me. And we just launched a brand new free infertility support community and app. So if you're not already on there, I think some of you are, but that's also a great resource for your journey.
I'm a member of it. I think it's fantastic. So if you're not a member already, I highly recommend you join. I'm going to introduce our first panelist, Dr. Tamika Zori. Dr. Tamika Zori is a reproductive endocrinologist and infertility specialist and board certified OBGYN. She completed her residency in obstetrics and gynecology at St. Vincent Hospital in Indianapolis and went on to graduate from the Reproductive Endocrinology and Infertility Fellowship Program at UCLA. We're super excited to have you join us today, Dr. Zori.
Thank you. I'm happy to be here.
And next, I'm going to be introducing Dr. Deborah Keegan. Dr. Keegan is a board-certified RE, reproductive endocrinologist, and general OBGYN at IRMS, the Institute for Reproductive Medicine and Science at St. Barnabas Hospital. She received her medical degree from NYU School of Medicine and completed her residency in obstetrics and gynecology at Bellevue Hospital, NYU Langone Medical Centers. She completed her fellowship at the NYU Fertility Center in 2007. Thank you so much for being here with us, Dr. Keegan.
Thank you guys for having me. I'm excited.
And our third panelist is Erica McCaffey. Erica is a birth and bereavement doula, grief and fertility coach, First Lady of Gaskins Chapel AME Church, and mom to 2 angels in heaven and 1 rainbow baby, Maxwell, also known as Super Mighty Max. She is the founder of Sisters in Loss, a grief and fertility coaching company that helps Black women replace silence with storytelling around pregnancy, loss, and infertility. Erica, we're so honored to have you be with us today as well.
So I wrote this in the chat, but to any of you late joiners, you can feel free to drop any questions in the chat box and we will try to get to them throughout the course of the event.
So the way that we've structured the event today is Kristen and I are going to ask our panelists several questions and allow them to answer. And then we'll open up the floor to all of you to ask your own questions or comment on the discussion that we just had. So Dr. Keegan, I'm going to start with you. the coronavirus crisis has dramatically changed the way healthcare professionals are able to provide for their patients. How has COVID-19 impacted your practice, and how have you shifted the way you work with patients today?
Big question, right? And where to begin, because it's an ever-changing landscape with COVID-19 and coronavirus. So I guess what I bring it back to is March 17th, when I think about the beginning for us. And that was the day, I believe, that the ASRM, the American Society for Reproductive Medicine and Science, issued their recommendations that with the pandemic upon us, fertility treatment should be suspended. The recommendation was to preserve resources that we, weren't sure we were going to need, that we may be using, and also due to the uncertainties that are still uncertainties with how this virus would affect pregnant women. But with that in mind, we're in New Jersey, and I'm based out of an office. Our laboratory and surgery center is in Livingston, New Jersey. For anybody that knows New Jersey, that's sort of north central. I'm in the Princeton area, and our governor, essentially suspended all elective surgeries kind of at the same time. So there's that added burden of having to stop treatment. So we had patients in cycle that week doing their IVF cycles, patients that were doing IUI cycles, patients preparing for transfer, some of which we had to, counsel and cancel because of the stay-at-home orders, because of the executive orders that were, basically forcing our hands. And we were also, I practiced with a group of 8 women, and we were also unsure of what was happening. I don't think anybody really knew. And so to err on the side of caution was our approach, to take care of our patients and our staff, not knowing how serious, how deadly this virus was going to be at the time. So essentially we went from full throttle to full on put on the brakes, and spent that entire week reorganizing the practice to finish the retrievals that we needed to, counsel and cancel a lot of patients, close the offices, and move from what we always knew, which was a hands-on approach in medicine, seeing our patients, doing their ultrasounds procedures, talking to them in person, holding their hands, giving them hugs, to not talking, and then having to move that into a telemedicine atmosphere. And I have to say, 4 months later, things are still changing, but we've been able to navigate the most important part, which I think is communicating with our patients and being able to continue to care for them, counsel them, and give them the information that they need, and also the treatment that they need, during this time. So that said, what has happened is we've shifted from a very in-person, hands-on approach to practicing to a telemedicine and in-person paradigm. So all of our consultations are done now through various platforms where we discuss the patient's history, results and plans, treatment outcomes, all the things you would talk to your doctor about in person, we now do virtually. And we were lucky in this time, I think, that we were so advanced technologically to be able to continue to communicate. That communication was key. As the restrictions lifted, again, with this ever-changing landscape that is COVID-19, we very slowly brought staff and patients back to the office. And the way now we do things is very different. We follow social distancing protocols. We schedule appointments and stagger them. We've physically staggered furniture in the office so people aren't close together. We require masks, screening questions, and take everybody's temperature. And we are constantly informing our patients through texts and through our website what changes are occurring. For instance, now we have, I think, 19 states in New Jersey for which people that coming into the state from those states have to quarantine for 14 days. So we're constantly keeping up with what we need to do to be in line with those orders, but also to be able to continue to care for our patients and keeping them and our staff safe. Testing, that's another thing. We need to test patients before they have any procedures in ambulatory surgery centers, because we don't want to place the anesthesiologists and the staff at risk. And that, that's been another thing. And of course, there's a window of time for which that has to be done. And so everybody, most people that have done IVF and the physicians know that you can't predict exactly when a retrieval is going to happen, which is your day in the ASC. So we had a lot of fun in the beginning chasing the right day for when to test the COVID. So it was in the 96 hours before we can get them into the ambulatory surgery center. And luckily for us, it was extended to 144. So that's another protocol we're following. So getting those tests, tracking results, making sure, they're within the specified time frame, communicating with our patients, counseling our patients about COVID, keeping them separate in the office and giving them access to us as much as we can through our telemedicine platforms is what we look like right now.
That's amazing.
Pretty busy. Pretty busy.
Thank you. The next question is for Dr. Tamika Zor. The coronavirus has devastated many fertility journeys, especially because of the cancellations of cycles and appointments. How have your patients been able to continue their fertility journeys while at home during this pandemic?
Yeah, like Deborah said, when this first started and having to call all those patients and essentially put all treatments on hold or on a pause was difficult. I'd say all my patients were very understanding, but rightfully so, sad about that. And so, that was a whole emotional aspect in and of itself when you've already been struggling on your own to conceive for months to years to then be put on pause is so difficult. But with some patients, the ones who have maybe just presented to care, who were probably going to be IUI cycles anyways, that was probably a good time for those couples, to try again at home for a couple more months, really focusing on ovulation timing and timing intercourse at the right time. For other couples who, they were going to be in the thick of IVF, it was a time to pause. I know I had some patients who were getting ready to go into a transfer cycle that month that we had to close down, and it was a time to just kind of reflect. And I touched base with her throughout this time, and some of them were just trying to focus on themselves in terms of their health, their well-being, adding exercise to their lifestyles, changing diet, getting, mentally and emotionally ready to restart treatment once we could. And so, it was a sad time that we had to pause, but for some, I think it helped them just to kind of reset to get ready for the next steps of this journey. But it definitely isn't easy. And, my heart goes out to all those patients who had to pause treatment because, this is such an emotional journey already. And to have to postpone it months is difficult. There were a lot of patients who were hoping for 2020 babies, and just with timing, that's not going to happen now. And so now they're looking towards 2021, and that it's just hard to wrap your head around that. But, the patients have been amazing. I love our patients, which is why this field is so rewarding. But it's been difficult.
Thanks, Dr. Zori. Dr. Keegan, another question for you. As states reopen, many women are nervous and unsure about going back to the clinic and balancing fertility treatments with everyday life. How are you navigating these uncertain times as you begin to reopen?
I think it goes back again to communication and the things that we're implementing within the office to keep not ourselves safe, but that absolutely translates to keeping the patient safe, right? It's kind of, organically, if we're all wearing masks and taking temps and screening, and we're doing the same, and we're cleaning, constantly, we can provide that reassurance that we're doing everything we can to keep our patients safe. We're also talking to patients a lot about what it means to be pregnant during the COVID era and deliver during the COVID era. And if you guys have been watching, that keeps changing. It started with we, meaning everybody that was looking at pregnant women, looking, at the demographics, that pregnant women were not at any higher risk for complications due to COVID than non-pregnant women or non-pregnant people. And then most recently, the CDC said, well, in fact, pregnant women are at higher risk for complications due to COVID than non-pregnant women. And that really, to me, wasn't too surprising. And Dr. Zori, I probably would agree, because with the flu, it is, respiratory physiology in pregnancy is compromised, and it makes sense that any respiratory process, like a viral disease, like the flu, should have some effect, a more compromising effect on pregnant women. So that part didn't surprise me. I think I was more surprised when I heard that, pregnant women shouldn't worry. So what we talk to our patients about is just keeping themselves safe, pregnant or not, hand washing, not touching your face, not risking being in large groups where you don't know, where people have been or how they've been protecting themselves and who they've been in contact with. So we talk about the same common sense things. We reassure them that we're doing everything to keep them safe, us safe, everybody, from this disease, and we continue to watch it, and we constantly change our counseling. And we're talking to, I think like Tamika said, it's been so hard on them and on everybody. So the more we talk and the more, we're in touch with them, I think they feel supported and reassured, so that's some of the ways that we're just, keeping everybody in close contact with what we're doing as things continue to change.
So the next question is for Erica. Your blog and podcast create a space for Black women to feel less alone and tell their stories when it comes to infertility and loss. Can you speak a little bit on the inequalities within our healthcare system and how they affect Black women with infertility?
Yes. So I love the discussion so far, especially as a doula and being able to support moms as they are trying to conceive and be pregnant during this pandemic. But as far as statistics that really flow and talk around Black women, we already know the statistic around just women in general, but Black women in general experience fertility challenges twice as our white counterparts. And that's mainly due to a lot of underlying health conditions like uterine fibroids and PCOS and endometriosis that are typically undiagnosed in most women of color or Black women. And it's typically, shunned off for other type of conditions. And it takes a while for a lot of people to get diagnosed with those conditions. And then when they get to the position where we're having children later in life, right? And they're ready to try to conceive, then they find out, oh man, I have these fibroids. I actually have this endometriosis. I don't have a regular 28-day cycle. What is really happening to me? How do I really take charge of this fertility issue and not, go through the process of loss after loss after loss just to find out exactly what's wrong? Another thing that is happened in the community and the women that I interview for the Sisters in Loss podcast, they have a lot of unexplained infertility where they just don't know why they keep having recurrent miscarriages. And I'm so happy that you all are here because definitely would give me another point of contact to point some ladies in different directions to get a different opinion on just hormonal treatments that they should be taking, different tests that they should be asking, questions they should be asking their REIs. And MFMs if they go there. And the other part of it is the mental health perspective, right? You all talked a little bit about just the emotional toll it's taken on a lot of the women who have had their treatments put on hold and the women who are actually pregnant right now. July is Minority Mental Health Month, and I've been really focusing on telling a lot of the women in my community to go out and get therapists and get counselors, especially if they are in this limbo of uncertainty right now in their pregnancy and journey to motherhood. So.
Can I add to that?
Yeah.
Erica, you point out something that is so important and something that is so often overlooked in fertility in general, and that's the emotional support, right? So that message, I think, for this group and anybody else is that it feels so lonely to be going through a fertility journey, to feel infertile, to feel what that means, to not feel normal. And I saw, and I think it was an UVA post on what normal really means. And we can talk about that later, I think, because I think that helps if you dissect what you think normal means. But Erica's point about, accepting and embracing and even looking for emotional and mental health support is so important and has to be part of this conversation, not just during COVID, definitely for minority women who have fertility issues, because that access is difficult to begin with, but I definitely wanted to, highlight that and underscore that. So thank you for bringing that up.
Absolutely.
Agree.
Thanks both Dr. Keegan and Erica. Dr. Zori, in your opinion, how does systemic racism influence fertility care? I think it was a perfect segue into that question.
Yeah, Erica and Deborah both hit on very good points with that. And one, I think it goes back, a little bit to what Erica was saying, that, and with Deborah, that, this experience feels lonely for a lot of women. And, especially living here in LA and, the world of celebrities, when you see certain celebrities, whoever they are, coming out with, having babies at over 40 and et cetera, it kind of gives a false representation to women, either that, getting pregnant or trying to conceive is easy, which it's not always for everyone, and the process that goes into that. And so I think that's definitely something to be aware of. And also the fact that a lot of Black women feel like they are alone in this because there aren't as many Black women talking about this. And so the ones that have spoken openly about this have done, wonders for patients, because they've shared their journey of, their own infertility struggles. And I think that does a lot for women in general. With systemic racism, and this is a term that I've come into recently, is a term called weathering. This is a phenomenon or a term that describes the advanced physical aging that Black women may undergo compared to white women due to their systemic discrimination and injustice that they've experienced throughout their life, chronic exposure to this stress that they experience. And it's possibly a way to explain why Black women and Black people in general have higher rates of chronic disease. So this could include, this is diabetes, hypertension, infertility. Black women's bodies go through advanced aging because of this chronic stress in life, and that potentially could be one explanation to describe what is happening with our infertility journeys. And then just another issue that we're dealing with is just implicit bias. When women in general even go to a doctor, there have been studies that show that they are less likely to be taken seriously, for their symptoms to be discussed and talked about. And this also is especially true of minority women and Black women. And so I'm a very big advocate of patients. All women need to be an advocate for their own health and their body. You know yourself better than anyone else, better than the doctor with all the letters behind their names. And I think that as women, we definitely have to be more in charge of our own journey in our own healthcare. And I think finding a doctor who you have a rapport with and a connection with is really important, because you want to have open lines of communication and you want to have trust. I think it's really important that you trust your doctor, because you're more likely to follow directions or, ask questions and, get information that's going to help you. And so I think really feeling a comfort in your doctor is really important for patients that are seeking any kind of care.
That's great advice. Erica, so you describe your platform as a community of Black women replacing silence with storytelling. In your opinion, how can members of the fertility community better listen to and amplify the voices of Black women experiencing infertility?
Erica, I think you're on mute.
Yeah.
Oh, awesome. So some ways that members of the fertility community can help amplify these voices is by, really allowing women to share their stories. Dr. Deborah mentioned that this journey is extremely lonely, and sometimes just having that one-on-one attention with a patient or a client, or especially people who want to, as far as therapists, counselors, and coaches, for them to just be able to share and get that message out. One thing that the podcast does for me, it just normalizes it. It brings it back to a baseline and really shows people that this is a normal journey for a lot of folks. It's extremely common, and it really doesn't matter what path that looks like for them to get there, to wherever their motherhood or their parenthood journey is. it's a journey for everybody. So I would just say just to continue to speak to it, share the stories and be open and honest and with your patients or your clients or whoever you're working with about their fertility challenges.
And I wanted to add to that too, just knowing for women in general that infertility does not discriminate. There's no discrimination of infertility with race, class, socioeconomic status. It can affect anyone, anytime, anywhere. And I think it's, again, really important that women realize that, and that we speak more openly about that, because it's still, while it's definitely talked about more, I know we can do better to really inform women about their fertility and make sure that everyone is aware of it, what they can do to take charge of it, and just the resources that are available to women in general.
Absolutely. Our next question, Dr. Keegan. The COVID-19 crisis has caused widespread devastation and highlighted the disparities in our healthcare system. What lessons can we learn from this healthcare crisis?
Okay, definitely for sure that nothing is certain. What you think you have today can be gone tomorrow. What you think is normal will be abnormal tomorrow. And I think we need to take from some of the things that Erica was saying and learn from each other and support each other. And when I think about it in terms of the fertility journey, because I'm not going through it, I can be as kind and compassionate to my patient as I know how to be. But there's still something that is different about telling your story, what you went through, to someone who's going through it, or sharing that experience. And I've read something that Tamika wrote too, about the disparities and women not wanting to talk about it. But in order for us to get to the point where we can provide access, I think access is passive, right? We need to be active in getting out there to show everybody that there can be access, and that's what we have to figure out. And something just clicked today with what Eric is doing. Maybe it really starts with giving our patients those voices, making them realize that normal is not a real word as far as I'm concerned. The sun rises and sets, that's normal. And I think the earth spins on its axis, and that's normal. But everything else is like, if you think of a bell-shaped curve, and you think of the area under the top of the curve, right? That's whatever it is, 68% or something like that. That's most things. But think about the unique parts of that curve on the outside, right? Like what's happening in the other, all right, math here, 30-something% out there that just is special and unique and can contribute to what we need to do, how we need to get there. It's taught me to rely on people more, Amy. We had to talk to each other as practitioners. We had to talk to our patients, what was working, what wasn't working, what can we do to make it, easier and more seamless for patients to continue to feel cared for when they really felt like they were being abandoned, and not necessarily by us, but to be told in the middle that you have to stop your treatment. Getting back to Tamika's point earlier, I mean, that was devastating. Those calls were horrible to make. So I've learned to dig deeper. I think we've, like who we are and who we can be to help lift each other and, and really navigate these journeys in the uncertain times together.
We're all in this together.
That is true.
This question's for Erica. The Black Lives Matter movement has gained unprecedented widespread support in the past month. How can we keep up the momentum to ensure the changes we need to see?
We still need birth justice and reproductive justice when it comes to Black lives across the healthcare system, but definitely when it comes to Black moms and babies. We all seen the numbers, just recently, another young lady's passed away at a hospital in Brooklyn due to just not being heard in her care. And we don't want those numbers to continue to rise. So we want to make sure that we are out there, we are advocating, we're being allies, we're hearing and understanding our clients and our patients, and that the women that are here, that they do, like you said, take charge of their fertility and really understand really what's going on, not just within their silos, but across every aspect when it comes to socioeconomic and race and gender, when it comes to fertility challenges and reproductive justice as a whole. So I would just say be informed, understand what you can do in your community, and definitely just keep your eyes on the things that are happening and which you can do physically to help change those numbers.
Amazing. And Dr. Zori, in your opinion, what can be done to improve the racial disparities found in healthcare and fertility care?
Yeah, and that's a big question. It's something it's going to take time to actively change this. But, little things like that I've, recently kind of learned more about are just even representation in medicine. Black doctors make up about 6% of all physicians in the US. But Black people make up 12 to 13% of the population. So Black doctors are underrepresented. Black female doctors are significantly underrepresented, making up maybe 3% or so of that number. And that does matter. There was a good study done that came out of Stanford that looked at 1,300 Black men who were assigned to either a Black male doctor or a non-Black male doctor. And the ones that were assigned to a Black male doctor were found to take part in their care significantly more than the other patients. They were more likely to get recommended treatment and preventative services done that their doctor recommended. And the authors and the researchers determined or concluded that they thought it was because of an increase in trust and rapport that the patients felt with their doctor. And that's not saying that every patient has to see a doctor of their own race. That's not what I'm saying at all. I think it's just that there has to be a better representation of all races in medicine so that patients have access to doctors who that they can connect with. And so I think representation definitely matters the most. Again, access to care and just being able to afford care. Again, we've seen the numbers of these awful maternal mortality rates of Black women having almost 3 times the rate of maternal death, preventable maternal death compared to white women. And these numbers are terrible. And this again goes back to probably coverage of insurance, being able to seek out prenatal care, and just being able to afford treatment in general. And so even with fertility treatment, we know it's really expensive for a lot of people. And for women to be able to afford that, we have to figure out ways to make it more accessible for all women and equal and accessible. And so these are going to be big questions that I think our field really needs to sit down and think about so that we can have more equal representation and access to care. I had several patients, come to me, Black women who, they didn't know where to go. They didn't know what to do because they're like, no one talks about this in my family. Like, I don't know any Black women who went through this. When I look at pictures online, they're of white women. They're like, do Black women even get infertility? And I look at her, I'm like, of course they do. And she was being serious because that's what she's seeing. If you go to even your clinic website, like an easy change is that any fertility clinic, go to your website and look at the pictures of patients and just your stock images. And do you have Black people or minority people in those pictures? Have representation of the women, the couples, single men, single women, gay and straight couples who go through this. It's not just, white couples. It affects everybody. And I think, again, representation matters, and what you're seeing contributes to patients not wanting to come in because they think I shouldn't have this. And that's so unfair, and it's doing such a disservice to women. So, this is going to be a big conversation going forward about what we can do, but I think those are smaller changes that we can try to do moving forward.
I think that's great. That's such a simple thing that would cause such a drastic impact in the community.
And of course, advocacy and access to coverage, and how employers, what they're willing to include in their benefits, and because what I find, a lot of Black women, the jobs that they have, and they're working no less and no less hard than anybody else. And most, a lot of situations much harder. They don't get the coverage that will afford them those benefits, you know, for prenatal care in an office other than, you know, a clinic which serves its purpose, but they don't have a choice. And when does that choice come in, you know, to empower them to make choices about where they want to be seen, what kind of treatment, you know, they want. And it's like Tamika says, like, we don't have all the answers, but the conversations have to start, and then the ideas can, you know, be born, and we can keep talking about it. And maybe if we just keep talking and the numbers grow, some of these changes that we're talking about that almost seem like dreams, you know, can really start to come to fruition. I mean, that's my hope. That's why I'm here today talking with you ladies.
Yeah.
Yeah.
And I would add to that I think that the next level above all of the access to care and the monetary portion of fertility treatments is the political perspective of it. You know, what is the federal government doing around this issue? You know, what are the bills that are being passed? What are the laws that are being passed? How is that going to affect our country as a whole? And that is ultimately where we need to go. Like, that's where it always kind of comes back to politics, but it does. That's where ultimately it needs to happen, where there are bills where people can get that access that they don't have access. And then you will have more Black people actually having the funding to go and get additional fertility treatment that they don't already have covered under the insurance, and they don't have to come out the pocket for it. So.
Right.
So because this question is sort of related, I thought I'd throw it out there. Shamela is asking, as a mental health therapist, I am attempting to support other women of color as myself during their infertility journey. Any advice on where to start or resources I can point them to?
Yeah, one site I really like is Fertility for Colored Girls. It was started by Reverend Dr. Stacey Edwards Dunn, who went through her own infertility journey, and she has a great network of different groups around the country that support Black women. They have, I think, a very active Facebook group that talks. They have, like, I think, a weekly prayer on Monday mornings. I think that's a really good resource, as well as Broken Brown Egg on Instagram. They have great resources as well. And I think there's another Facebook group, Black Women in Infertility, that is new. I would definitely start with all three of those.
And I would add for mental health providers that are interested in helping women who are struggling with fertility, the ASRM, the American Society for Reproductive Medicine, has the mental health professionals group. And so mental health professionals can join that group, and they will be, you know, sort of, there's a lot of opportunity there to bring these issues to the table in a national setting. And I have no idea how many people are on that, you know, how you get certified for that, but it is a certification. And I think then we can also bring, you know, some of the concerns we're talking about here directly to the ASRM through that group.
And then I also would add, obviously, Sisters in Loss in our Facebook community, but the Black Women in Infertility actually has a therapist directory that focuses on women therapists around fertility. So I would go and join that group and contact Siobhan. She is the head of that group, and she can definitely give you and point you into that directory. I want to say it's a Google Doc or Google form of therapists that really focus on fertility.
Well, thank you. So these questions are open to all of our panelists. When entering what many describe as a new normal moving forward, what changes do you hope to see?
I think one, with our new normal, I know that I personally miss, like, hugs of patients. I just want to, like, go and hug people. So I think just making sure that we can maintain the closeness that you feel with your fertility doctor, even though we're maybe not getting as close and touchy as we're, you know, saying goodbye if you've graduated treatment and everything. And I think just maintaining that personal level that I think a lot of patients feel towards their fertility doctors and their clinics, just because of the emotional journey that you go on with that clinic. And then again, I want this to continue to spark conversation, and I want women to feel informed about their fertility. I think it's been this topic that is just now becoming more of a conversational item in the past maybe 5 years or so, and I think we need to do better. I hate when I have a 40-year-old plus patient who comes in and says, I didn't know this about my fertility. I wish I would have known this. I don't, you know, if you're 25 and 30, like, I want you to know this now, so that if you choose to take steps to help your reproduction, and whether it's egg freezing or embryo freezing or doing nothing, that at least you're aware of your choices. And I just think continuing awareness for all women is really important going forward.
And I think to follow that, what I hope to get out of the new normal is that we just by, you know, practicing virtual medicine, we can provide more access, because look at all of us here together on a Thursday afternoon, where we would never be together without, you know, this particular Zoom platform. So what I'm finding too is that if a patient can't leave work to come to a doctor's appointment, because the doctor's appointments hours are, you know, 9 to 5, I do a telemedicine consult at 6 p.m. because I can. And that, I think, alone will give patients more availability, more, you know, and that counts for access too, that they can actually start those conversations with healthcare providers. And there's something about doing it from home and doing it, it's less intimidating, I think, than to walk into an office that, you know, smells so clinical and is so bright, that you have the comfort of your pets or your, you know, your partners or your kids or your just, you know, the pillows in your house. It makes it a little bit more intimate. I'm really finding 4 months later a lot of positives about, you know, the virtual encounter. You learn a lot, you know, about someone when you see what's going on in the background, and, you know, the dogs and the cats, or what's on the fireplace and the pictures. So I'm hoping that we take advantage of that and continue to utilize technology. Hopefully, you know, that explodes, and then we are able to talk to more people in the same amount of time.
I would agree with that. Oh, sorry. Go ahead. I was just going to say I would agree with that. With virtual support groups even, I think, whereas it was a little bit more intimidating, another appointment on top of an already busy week of appointments, I think the fact that people can kind of just log on from home, and we've had some really amazing discussions virtually, it's just beneficial for all.
And then I would add that I would want to continue exactly what you just said, that this new normal creates a virtual community for people to really share more about their fertility challenges and what they're going through, just so they can get that support that they need. And just that, you know, because people understand exactly what it feels like to go through an IUI after IUI and then have to go through a full IVF cycle and what that looks like. So I just want that the virtual community to come in and really fully hug people, you know, and virtually, as you can't physically hug people. But as a doula, on the doula side, you know, obviously this is a lot of hospitals are not allowing additional support in the hospitals. So it's changed into a whole virtual world as a doula, and supporting clients through their labor and postpartum period. So I want it to go back to where we were, but in this new normal, I'm thankful for the virtual clients that I can have and support them through their, you know, after their losses and their pregnancy after loss to their rainbow baby. So.
Thanks, guys. And a last question to the panelists from our side. How can we do better, ensure equality, and make the fertility community and fertility care more intersectional, empower women to better understand their fertility? Are some examples, but like, what do you think we can do better moving forward?
I think it always goes back to education, I think, and that's always been the challenge. Where do we go? You know, we talk about access, but like I said earlier, we have to be active in getting the access out there, getting the knowledge that there is access, right? I mean, there's got to be so many people that could dial any one of the three of us up on, you know, for support or consultation, but just don't know it. And so I think that getting into the communities, getting to the places that don't know that fertility care exists and can continue to exist in a virtual world, and the conversations can be had. I think there's a lot of opportunity there, and that's the part we all need to get together and figure out how to do it.
I agree. Definitely. I think it always goes back to education and just women knowing about their fertility and how to get this onto a big and broad platform so that, you know, everyone can hear this message. I think is definitely very important.
And I think, you know, if we think back to physiology when we were in medical school, right, and you learn about reproductive physiology, you do learn what's supposedly normal. And I think we need to change that. I think we need to talk about what's individual, and that perhaps there's a prototype and there's an example, and the 28-day cycle can be an example, or time to conception of less than a year under 35 can be an example, but that it's not necessarily normal, because it's not normal to that individual. And the second you attach something as abnormal, you're devaluing how that person feels, you know, about themselves in comparison to others, to everybody else. And that's not what it's about. That's not how we want to lift people up. So we could talk about that on the side, how we should maybe suggest that to, you know, medical schools, and that curriculum, changing the, you know, the verbiage is important, I think.
And I would challenge and go even further back than that and just take it back to like middle school and high school and talking about reproductive systems and really what reproduction looks like and fertility looks like. Because in my own personal journey, you know, I had to have a hysterectomy to save my life, and I have not been able to retrieve my eggs. If I would have known back in my 20s that I was going to have all the challenges that I had in my 30s, I would have froze my eggs in a minute. You know, like that would have been the first thing I did right out of college when I got a good job, right, and had insurance that covered it, or just use that money to do so. So I think we need to go back further than that and just say, hey, let's really take a holistic look at our bodies as women, and not get on, you know, other things, do other things, and really understand what our bodies are doing outside of that 28-day cycle, outside of, you know, not having cycles consistently and heavy menstrual cycles in general, and really give our, you know, younger siblings, younger cousins, younger, you know, patients that we have the opportunity to really understand exactly what it could look like in the future, especially if they're going to have children later in life.
And you're so right about that, because and infiltrating, my husband's a teacher, and infiltrating those state curricula are like, it's impossible.
Absolutely.
But as a result, for the last 10 years, I've been doing community outreach, sex education for middle schoolers and high school. And we talk about that because they have a notion already of what it's supposed to be like. They learn that in school. So if we can't get to it, you know, in the schools, we can get to it in these little groups in our communities where we can, you know, talk to these young women, these girls about, you know, this lack of normalcy and what to expect, that it's not, you're never going to get what you expect. We need to teach them to learn to deal with the unexpected. And this was a great you know, example of that. COVID-19, the whole world dealing with the unexpected. Yeah.
And yeah, I was going to add.
Sorry, go ahead. Do you have any resources that you can recommend for those in their 20s and 30s and even 40s who are looking to learn more?
You know, I can't say off the top of my head about what in general. I'm sorry.
I guess if they haven't learned all of this in school, for those who are just wanting to become more knowledgeable about their fertility health, but they're not yet trying to conceive, are there any resources that you can recommend?
Well, the things we're talking about when we want to sort of veer away from the normal, like any resource that is out there right now is going to give the, you know, the typical experience. Yeah. Like, so that's why I'm struggling with how to answer that, because there are a ton of resources.
No, that makes sense. Yeah.
Yeah, but it is going to be what the book answers are. So.
Right.
Yeah. I think it really comes down to removing the stigma, like how this whole topic of reproductive health and infertility is stigmatized right now. And just kind of trying to break those walls down brick by brick.
And I was reading some of the kind of chat questions on the side, and and I agree with education. I feel like as middle school, high school, we're taught everything to do not to get pregnant. And we unconsciously assume that the second we get off birth control, we will accidentally get pregnant or oopsie, get pregnant. So I think that, you know, even though we go through our lives just thinking that once we get off birth control and ready to have kids, we're going to be able to. And so then you become 25, 30, 35, and you're like, what is happening? You know, I was on birth control for 17 years. Had I known I was going to struggle for 2 years, you know, what was this point? And so I think we have to really go back and actually teach like fertility health to high school kids and to college students about, you know, women especially we have a finite period to get pregnant and to conceive. We are not like men. We cannot, you know, get pregnant at 60 and 70 years old. Our fertility significantly declines by starting at 35 and definitely by 40. And that has to be a conversation that happens and that all women know about. And so again, that goes back to education and just in high school, even like this has to start early.
Absolutely.
So we're going to open up the floor to questions from the audience. I know we have about 7 minutes left, and we've been getting a lot throughout the event. So if it's okay, Kristen and I will start asking each of those questions. The first one is from Gayatri. What is your advice for women trying to conceive in the age of COVID, given that so much is unknown on how the virus actually affects pregnancy? And I think Dr. Keegan, you started answering part of that early on, but maybe you can embellish a little more.
Yes, I think to Tamika's point, if you're thinking about conceiving, then it's you know, the sooner the better. And that's, you know, with COVID aside, you know, the younger you are, the more likely you are to have success in conceiving in a healthy pregnancy. So anybody, you know, we're never going to stop populating, right? People are never going to want to stop establishing families, and they've done it in the face of, you know, dramatic, like tragic times on planet Earth. So we have to keep going, and we have to, you know, learn from these experiences, and we are resilient and we can do this. What needs to be done, of course, to feel safe is to keep yourself informed of what is happening in your state, in your community, how much of the virus is out there, you know, and again, it goes back to just following those rules to try to keep yourself from getting infected. I had a conversation with a bunch of nurses in the operating room the other day when I was doing IVF retrievals of their friends that are ICU nurses that work on the COVID floors, and who has not gotten the disease. You think if anybody's at risk for getting it, it's the, you know, nurses that are with these patients constantly, right? Hour after hour, minute after minute. And they said the key is the protective equipment, the personal protective equipment. So I think that's a huge thing to keep in mind, that is, you know, all we know with all this uncertainty is it's the one thing that could potentially keep people safe, pregnant or not. So I wouldn't suspend plans. I would say, let's go. I mean, listening to Erica, if she had only known, right? So I don't think people should wait. That's my personal opinion, because I think we have the ability to keep our patients informed and safe, you know, as do our OBGYN colleagues throughout the rest of the pregnancy.
Yep, agree.
Did you want to ask the next one?
Yep, so this is about physiology. Are there any studies? Sorry, I'm just scrolling to it now. Are there any studies looking at the link between general physiological aging and ovarian aging?
Off the top of my head, I can't.
Yeah, I'm not sure there's something specifically related to that, other than, you know, what we know about ovarian aging in general, and with chronological aging, ovarian aging, it's not linear, because there are some very fertile, you know, 42-year-olds, but there are some very you know, infertile 32-year-olds. So that part of the relationship we know, but I don't think there are any specific studies looking at that question.
Yeah, I can't think of any again, but I would agree. I think it's important to know that everyone is so different on their own fertility curve. Again, there might be, like Deb said, there are people who are 42 and very fertile, and then there are 30-year-olds who have ovarian reserves like they are in their 40s. And so I think that it varies definitely on each person and that person's age and how easily it'll be for them to get pregnant when they try.
I think there was a great conversation that happened while we were talking about the importance of education early on in middle school and high school. So if we did address your question, Brianna, then please feel free to re-ask it. But there is a question from Erica K. She plans on doing her own research, but do you have any resources off the top of your head to learn more about reproductive justice and ways to provide support in that aspect of the Black Lives Matter movement?
Black Women Birthing Justice is a great resource. Medical Apartheid is another good resource. These are all books that you can just Google and they'll come up on Amazon. And then another good book is, oh man, I can't think of the name off the top of my head, but it's by Dr. Deidre Cooper Owens. It's another medical terminology book. Medical Bondage, yes, she put it in there, yes. So that's another good book that talks about birthing and reproductive justice. And there's several others, but those are the three off the top of my head that really will give you a full aspect of where we were, where we are now, and what we need to do to continue to move forward.
So for all of the references that everyone has made throughout the discussion, we're going to reach out to all the panels to get those exact resources, and we'll send it out to all of the attendees after the event, just so no one feels like we're missing anything.
So the next question is from Tiffany, and this will be the last one because we're almost out of time, but what is the fertility related recommendation for a woman with fibroids who would like to plan to conceive?
So, that's going to depend on where the fibroids are, I'd say is step one. If they're inside the uterus, those are the ones that tend to have impacts on either fertility or miscarriage rates. And so that'd be something to determine where they are, again, what her age is, how many there are, location, and that helps with planning. And so I would say definitely if you know you have fibroids and have not conceived yet, talk to your OBGYN and we get a plan of where these fibroids are so that you know how this could potentially impact your fertility. Some women have fibroids that do not affect fertility at all if they're outside the uterus. And so I think it's important to know, again, your own body and where these fibroids are located.
Agree.
Thank you guys so much for joining us today. I think this was such an insightful discussion, and we raised so many awareness of so many issues that are really ingrained in our system. So we can't thank you enough for joining us today, and thank you for everyone else that joined to hear the conversation.
Thank you for having us.
Thank you for having us.